and keep people as safe as we can during this. So I'm really happy to answer questions. I think they'll probably come through Tim's setup. There's a Q&A panel which you may have access to, or you may be able to ask them on the chat. But I'll maybe just give you a brief summary about where we're up to at the moment. As you know, there's just under 300 cases of COVID-19 so far in the country. We do expect that number to rise, and you've heard this in the media today, that we would expect that to continue to rise for another 10 to 14 days after the imposition of this lockdown, essentially. And so all our hospitals and medical services, and not just in haematology or oncology, but throughout the service, are preparing to expect a greater number of patients. Hopefully the lockdown's been put in place early enough to avoid the system becoming overwhelmed. And I'm optimistic of that in this country. But we're really just trying to make sure we can manage our service and make sure that we can still provide emergency care to people who really need it, and also minimize the risk of people acquiring this disease in or around hospitals. So I don't know if there's any questions yet, but if not, I think they're going to come through on the system from Tim. But if not, perhaps I'll just explain some of the things that we've been doing in our own centre so far. And some of these things you will have noticed. Some of you might have already started to have telephone consultations more than you might otherwise. And certainly this is something we're trying to do. A lot of hematology and oncology patients, it's often the case that what we're doing is reviewing blood results and checking how people are, and then perhaps prescribing medications. And for those people, it makes a lot of sense to manage those consultations by telephone if we can. It does a few things. It avoids you coming into a hospital setting where you might be at greater risk of getting infected than if you were to stay at home. It fulfills that broader public health objective of trying to maintain that isolation for everybody else, including the staff in the hospital, to try and minimize the spread of the virus and hopefully get us out of this lockdown situation sooner. And it's also partly about protecting the healthcare system itself. We want to reduce the chance that people get treatment complications that we would struggle to manage if we had a large number of cases in a couple of weeks' time. So there's a couple of questions come through on the Q&A, which I'll just address if that's okay, Matt. So what might happen after the 4-week isolation, and do we still keep away from groups? The 4 weeks is an estimate, is my understanding. So I'm not an epidemiologist or a virologist, but I would say that the 4 weeks isolation is an estimate. We think that there's about a 1 week incubation time for the virus after somebody's been exposed. And it takes about another week after first getting symptoms before most people get particularly sick with those symptoms. So it might take a couple of weeks before we see the full impact on hospitals. And we need to allow for people currently within their bubbles, within their home environments, that there might be transmission between people within that environment before it's stopped. So 4 weeks is probably a reasonable minimum. And it's not very likely that all the controls will be released at that point. That period might need to be extended slightly. Or perhaps more likely, it might need to be stepped down to level 2 or 3 on that government scale. And if you want to know more about that, that's on the government website. It's called covid19.gov.nz. And I suspect there will still be a recommendation that people who are very infection prone, which would include many people with blood cancers, there may still be a recommendation to try and stay away from others after that time. There's a question here from Julia. If I'm in remission and neutrophils almost normal, am I higher risk than the rest of the population? To some extent, it depends on the condition. The answer is quite probably not, but the neutrophils are only one element of your immune system function. Also important for fighting infections are the antibody levels in the blood, which after some chemotherapies, like those involving rituximab, can be lowered slightly or reduced for maybe 6 or 12 or even 24 months after the treatment. And the other type of cell is something called the lymphocytes, and they're particularly important for fighting certain types of viral infection and may play an important role for this COVID-19 disease. So the neutrophils coming almost normal, that's very reassuring. We think very severe neutropenia might be a risk factor, but it may be some more subtle effects on your immune system that go beyond that. I'd suggest still be cautious, and I would suggest particular caution if you've had fludarabine or bendamustine as part of your treatments, where we know there's an ongoing effect on the immune system for maybe a couple of years afterwards, and rituximab, where there may be an effect for a year or so. Bone marrow transplants are a different story, where some of the immune effects could probably last longer still. Natasha asks, is there any increased risk to patients who are post-chemo? Personally, 2 years out. Well, I think I've just addressed that. I think for most people, 2 years post-chemotherapy, I think the risk would be coming down. But I would caution that, to be honest, anybody is at risk of this virus. It's a risky virus, even in healthy people. And many people with blood cancers will have other risk factors beyond this malignancy itself. You know, some of you might be older adults. Some of you might have high blood pressure or kidney disease or lung disease. So that probably the risk to more than 2 years after the end of chemotherapy is probably not much higher than baseline, but you may still have other risk factors, and I still recommend taking all the recommendations seriously. I'm newly diagnosed with a diffuse large B-cell lymphoma. Should I be self-isolating before I start my chemo? Well, what a good question. I think the answer probably is yes. In practice, we're kind of all self-isolating anyway, and it's very difficult to self-isolate from those physically in your home. So I think I would suggest in the immediate run-up to an important chemotherapy like that for diffuse large B-cell lymphoma, that self-isolating is sensible. And I'd say, to be honest, at the moment, we kind of should be doing that anyway. And I agree, we often do have to defer treatment if somebody has what we think might be a serious infection, and that would probably include COVID-19 disease. So yes, I think you should pay particularly close attention, and we would not recommend, in general, we would do all we can to avoid deferring treatment for an aggressive lymphoma like diffuse large B-cell lymphoma. So really that protective isolation is really important. How risk are, there's an attendee asks, how at risk are those who are 1.5 years out from an allo transplant? Well, we know a lot of the immune function starts to come back by about a year after allo transplant. The exception is if people have ongoing active graft versus host disease and are still on immune suppression. So people even late after a transplant, if you're still on drugs like cyclosporin or steroids, your infection risk probably remains very high. We don't really know by about 1.5 years out from an allo transplant. So what we recognize at that sort of time point is that we often revaccinate patients at about a year after transplantation against childhood diseases, because we know that the immune system forgets protection against these diseases by that point. But of course, no one in our community, or only a handful of people who've recovered, actually have any immunity against COVID-19 anyway. So we don't really know. I think a precautionary approach would be sensible. And I think 1.5 years out, probably not hugely increased risk, and as long as you're not still on immune suppression, but there could well still be a risk, and I'd be careful about that. There's a question from Ron about, I have CLL, still in watch and wait. To what extent is my risk profile elevated because of this condition? Well, we certainly see an increased risk of chest infections in people with chronic lymphocytic leukemia, even before chemotherapy. That risk is not as large as after chemotherapy, so that's good. There are some guidelines that people with CLL, even before treatment, should be having the flu vaccine each year, and probably should be having the pneumonia vaccines. Now, those aren't funded, oddly enough, in New Zealand until you've had chemotherapy. I've been taking Pharmac to task over this one. But I would recommend, if you've got CLL, that you both get the influenza vaccine each year, and that you consider getting the pneumococcal conjugate vaccine. It's called PCV13, Papa Charlie Victor 13. And that fits with some of the European recommendations for people with CLL. We don't know whether CLL untreated increases the risk of severe COVID-19 disease. It might, but probably not nearly as much as being immediately post-chemotherapy. That sort of addresses a question there from Mark, asking similarly, CLL under surveillance, very low lymphocytes. Yes, so CLL is a chronic condition, and often but not always, the decision about when to start chemotherapy is a little bit flexible. So often we monitor people for a period of time when they're close to needing treatment, and eventually something might happen that might say, so let's get on and treat now. I think already right now, with us not knowing where this virus is at, it's definitely influencing some of my treatment recommendations. And there are some people for whom we're just on the cusp of needing treatment, where maybe 3 months ago I might have said go ahead. Now I'm saying, well, look, we can give this another 3 months without treatment and just get you through the peak of this COVID-19 disease before we start therapy, and probably reduce your risk then. So I have been recommending that to patients. It doesn't mean not to have treatment if you need it. If you really need treatment, it should go ahead. But it's sensible just to continue surveillance. You don't want to start a therapy that might cause a risk if it doesn't need to be started at this juncture. Ian asks, the police commissioner confirmed today people could go for a walk in a park. If we stayed in our bubble, is this safe for us? I think probably, as long as you stay away from people. I went for a run in the park today, and I found people were very respectful. Everybody was keeping a really big distance from each other, you know, running and walking out of each other's way, nodding and acknowledging each other. But I think you really just do want to keep well away from people, not touch shared things. I think you need to watch out for things like handrails and things where other people might have touched. I know at least in the parks here, they've closed the public toilets, which is worth bearing in mind before you go out. We had to brief our children first. So I think it's probably okay as long as you stay well isolated. CML on dasatinib with neutrophils low but lymphocytes normal. Any different outcomes or risk versus infection? That's a really difficult one, actually. We don't see huge rates of infections in people on the modern therapies for CLL, but we do get 1 or 2 viral infections, particularly hepatitis reactivation. We genuinely don't know about this for COVID-19 disease. If your neutrophils are low, you could check with your clinician about whether any measures are needed. Depends how low they are, but there's some people for whom we've been giving the occasional injection of GCSF to raise the neutrophil count. And depending on where you're up to with your treatment, there may or may not be a role for dose modification and lowering the dose for a while. I suspect not. If you've only been on for 2 months, it probably is important to get deeper into remission at this stage. If we get a COVID, would we stop chemotherapy? I think under all but the most exceptional circumstances, if somebody actually developed COVID-19 disease, we would probably pause their treatment. There may be exceptional situations for a very aggressive malignancy where we feel there's no other option. Most treatments we could pause for a couple of weeks, and it's often the case that we do that. For example, if somebody gets a severe infection of any other type, that we might pause treatment. And we're really thinking there for you about the benefit versus the risk of continuing. And we have to make that decision with imperfect information. Unfortunately, that's often the case for all sorts of other infections. And I think many people would be paused and then resumed when people are well again. We've had another question about CLL and watch and wait. I think we've addressed this. Going to supermarket would be fine. I would be, if you do have somebody else who could go to the supermarket for you, I would be cautious about that and see if someone else can go, either someone else in your household, or maybe there's a neighbor or friend that you could send a list to and they could pick things up and leave them out for you. It sort of depends how busy the supermarkets are and how rigorous the infection control measures are. But I think if I had a blood cancer that's known to be linked with the impaired immunity, and CLL and other indolent lymphomas, essentially anything that's not fully in remission and a long time out from treatment, I'd seriously see if there is another way of getting the shopping in for you during this potentially highest risk period. I think that would be sensible. And similarly, a question from Helen about on watch and wait with follicular lymphoma. I think similarly for the indolent lymphomas like follicular lymphoma, similarly to CLL, I think it would be sensible to stay away from people and take the recommendations particularly seriously and look after yourself in those respects. Once we know more, once we have antiviral drugs or vaccines, we can probably relax these a bit.
Hey, Rob, is it okay? There was a few questions in the chat box, the other chat box.
Yes, I can answer these.
So there's one, so from Simone, I'm sort of near the top. Simone said, I have asymptomatic myeloma and am not currently receiving any treatment. I have a low white blood count and low neutrophils, does this put me at a greater risk than the rest of the population?
I think probably yes. I think you're probably not in the very highest risk group, by which I'll put people who are currently on or immediately after chemotherapy, or people who have recently had a bone marrow transplant. But I think it would be sensible for you to regard yourself as being in a risk group and take those recommendations very seriously. And when the restrictions are relaxed, I would still put yourself in a risk group and be more cautious than other people to an extent, yes.
Okay. And then, can you see those, Rob?
I can see. What effect would COVID have if I'm on immunotherapy of venetoclax? Good question. We have quite a lot of patients on venetoclax. I think that is a treatment. We know that people taking venetoclax can get low neutrophils. They can get low levels of normal antibodies. And so I think that would be a risk factor. How strong a risk factor it is, we don't yet know. So we don't have detailed information for COVID-19 disease yet. And we're really extrapolating from other infections like influenza and so on. So for example, people on venetoclax seem to have a slightly lower response to the flu vaccine than people who aren't on venetoclax. And the same goes for ibrutinib. So I think I regard myself as moderately immune suppressed and act accordingly. We've asked a bit about CLL watch and wait, which is a very big deal because there's a lot of people in that situation. If you've had bleotoxicity, that's a great question. So bleomycin toxicity is an important one. So we wrote this guidance on managing people with cancer around COVID-19. And I think there are a few things that anybody with cancer should be aware of. So as the number of cases rise, what might happen is we might have telephone assessment of people with possible COVID-19 disease, or we might have community-based assessment centers. So centers out in the community that perhaps are run by GPs or hospital doctors where you wouldn't be seeing your normal doctor. If you go to one of those centers or either get telephone advice or see someone who isn't your normal doctor who's assessing you for possible COVID-19 disease, it's really important they know about your diagnosis and the treatments that you've had. And bleomycin is one of the examples of that. Bleomycin can sometimes cause a lung toxicity that causes low oxygen levels, dry cough, fevers. Those are some of the symptoms of COVID-19 disease. And so it's important that people know that you've had the bleomycin drug so that they can consider, could this actually be something completely different? And similarly, people with blood cancers might be at higher risk of having a bacterial infection. So whereas for a young fit person, it might be perfectly appropriate to send them home with some paracetamol and say, just take this and hopefully you'll be better next week. For someone with a serious blood cancer whose, say, antibody levels are very low, I think a much lower threshold for offering antibiotics in case it's a bacterial infection would be useful. So I've been suggesting that patients, if they can, either make a note of what their condition is and their treatments, or carry a copy of a recent clinic letter if you get sent your clinic letters, and present that in case, because you may end up seeing doctors who aren't usually involved in your care who might not know about this and might not know to watch out for it. So other examples of diseases that can cause funny lung conditions, treatments that can do that are immunotherapies like pembrolizumab, something called checkpoint blockade, not used very often for blood cancers, but sometimes for Hodgkin lymphoma. So that can cause a lung toxicity that looks a lot like COVID-19 disease. And we've suggested the same thing for that. So great question about the bleomycin. You could go with an alert bracelet, absolutely. You have to pay some money, or you could just carry a copy of a clinic letter folded up in your wallet and show it to any doctor you have to see. That would do the same thing for free. I'm due to have a phone consultation. If I have an issue with my blood test, will I be able to see a doctor face-to-face? The answer, I think, is yes. So we are changing a lot of appointments to telephone consultations. If somebody really needs to be seen, they need to be seen, and we will still, at least at our centre, be recommending that we see them, yes. So the idea is that we only bring in people to physically to the hospital who need to be seen. And if the blood test comes back and you need a blood transfusion or there's something concerning that needs further investigation, then I would expect that, yes, they might identify that as part of the telephone consultation and then ask you to come in person. So absolutely, I would expect that to be the case. Colin asks about, I'm 1 year in remission from AML. What is my risk profile? Probably not terribly high. Acute myeloid leukemia therapy doesn't, at least a first-line therapy, doesn't tend to have a huge ongoing effect on your immune system beyond a year or two. I would say mildly to moderately elevated. But then, to be honest, even someone with just high blood pressure is at elevated risk. So hopefully your risk isn't too high at this point, particularly if you have normal blood counts at the end of treatment. So Tim just wanted me to say, for those in remission, not at high risk, but might not cope with COVID-19 if you get it. So there are two things. There are the risks of catching the disease in the first place, and there's the risk of getting severe disease. To be honest, I think everybody's probably at the same risk of catching the disease. It's a very infectious virus. It's probably a little bit more infectious than regular seasonal influenza, but although less infectious than measles. So it really is a very infectious virus. And to be honest, I think everybody's probably at similar risk of catching it. What about severe disease? I think any number of things can put you at higher risk of having severe disease, but noting that even the youngest, fittest people can get severe disease, just less often. I think it's likely to be a scale in this sense. And for those who are have not had a lot of treatment or are in remission, they're probably not at much higher risk. But there are also known risks from having chronic kidney disease, chronic lung disease, high blood pressure, cardiovascular disease, smoking, and age. So all those things apply as well. And really, we can't disentangle all of those entirely. There is some evidence that cancer itself is a risk factor, but that comes from China, where most of the patients had lung cancer, and they may have also had chronic lung disease from previously smoking. So, but we do think there could be an increased risk, and that's why we're taking this precautionary viewpoint. I have regular blood transfusions. Am I still safe to have them? Well, that's a really, really good question. So first, there has never, to my knowledge, and we did ask a blood transfusion specialist to review this, there has never been a documented case of any coronavirus being transmitted from blood. So that's reassuring. Now, bear in mind that there are seasonal coronaviruses, other coronaviruses that are out there in the community that have been going around for decades or hundreds of years. It's just this is a particularly nasty one. So there, to my knowledge, there's never been a documented instance of a coronavirus being transmitted by blood, although you can detect tiny amounts of the genetic code in plasma sometimes, but it's not been shown to be transmitted. So that's reassuring. The New Zealand Blood Service has some stand down criteria. So anyone attending the New Zealand Blood Service they ask them specifically now about symptoms that might suggest COVID-19, and they get stood down from donating if they've got those symptoms. So there are some extra precautions being taken there. So we think the blood supply is secure. However, obviously to have a blood transfusion, you have to go into a hospital, sit in a chair, there'll be other people around, you're moving around, you're coming into contact with things, the nurses who might be giving you a transfusion. So what we're trying to do is be sensible and trying to minimize transfusion. And the sort of things that we're doing is saying, are there alternatives for some of our patients? Could we be giving more iron? Could we be giving erythropoietin to reduce the need for blood? And for those who are on a long-term transfusion program, we are saying, could we let the hemoglobin run a little bit lower for a while? You might find that your exercise tolerance is a little bit lower, but we can identify safe hemoglobin thresholds that are a bit lower that might increase or reduce the number of transfusion episodes that you require. And I think that's a sensible measure. And of course, I would say that I expect all units are taking measures to try and reduce infection chance in the unit. So, we're doing things like moving the treatment chairs further apart, extra hand washing precautions for the nursing and staff. So we're doing all we can to protect you. But if you need blood transfusions, you need them. And one of the messages is, if you've got a necessary treatment, it should be given. Otherwise, we're not being proportionate to the risk and benefit situation. Daryl asks, myeloma for 10 years on lenalidomide, would this affect my risk profile? Not sure. There are funny effects of lenalidomide. In some respects, it actually increases immune function. If you're getting neutropenic with it, that would be a concern. I would regard yourself as moderately immune compromised, because the myeloma itself and probably prior treatments that you've had for myeloma probably put you at some risk. Lenalidomide itself probably isn't too bad. Steroids, we do worry a bit about it. And in some selected patients, we're recommending reducing steroid doses. But do that in consultation with your clinician, because they know what the right risk benefit is for you. Do you know if supermarket services are planning on offering sessions exclusively for vulnerable people? I don't know that yet. It's a really good question. I recommend that you contact the supermarkets, contact Countdown, contact New World, ask them, put the questions to them on Twitter, email them. I believe in the UK they're offering supermarket sessions for older adults, and it would make sense if they were doing that to do that for other vulnerable people, such as people on treatments for cancer as well, particularly if the supermarkets get very busy. You might be able to also speak to people you know of, find out when the quieter times are and try and go in then, and rigorously, wash your hands before and after you attend, all those sort of measures. Approach for a patient with PNH. So paroxysmal nocturnal hemoglobinuria, yes, it can cause a low neutrophil count. I don't think a mildly low neutrophil count would be a strong risk factor, but if it was severely low, below 0.5, that may well increase the risk. The cyclosporin, if you're still on that, probably is a risk because that affects your lymphocyte function, and I think it's sensible to regard yourself at risk from the cyclosporin. On the other hand, don't stop it too quickly because the disease could bounce back very quickly, and then you could find yourself needing much stronger immune suppressive treatment at the worst time. So don't make treatment changes off your own bat. Do check with your doctor or your specialist nurse. CLL, is it wise to stay working? I think that is a tricky question. I think for early CLL that hasn't required treatment, the risks probably aren't enormous, but a public-facing role could be an issue. If you're physically not touching or staying away from anything the people in your work environment are touching, that might not be too bad. It would be one to talk about with your manager or occupational health department, I would suggest. There's a question, somebody's Samson's son had a stem cell transplant from his brother 187 days ago. So not on any treatment for GVHD. So 6 months post stem cell transplantation, I think the immune system is still weak. And I think it's really important, even without being on immune suppression, I think it should be regarded as susceptible to infections and should take all the precautions. Look, am I a risk to him? It's difficult when to be honest, when you live with someone, it's very difficult to avoid. You're within that same bubble and it's very hard to avoid spread. So you should take as many precautions as you can. Don't send the person who's had a transplant out for shopping. You go out for shopping, but then you also really, carefully wash your hands, really scrupulous about all the infection prevention. And I think that's the best you can do, because you may also need a support person to go out for him. Myeloma, autologous transplant a year ago, finished chemotherapy in December 2019 in minimal residual disease. So there probably is still some impact on the immune system after finishing the end of treatment in December 2019, especially with a bone marrow transplant as part of that. So I think maybe at slightly increased risk despite the normal bloods. Yes, there could be low antibody levels, for example, or dysfunction of the immune system. It's probably not the highest risk, but I would still be cautious. Should I wear masks and gloves to path lab and for chemo treatment? So what a great question. So if you have a mask, by all means, there may be some degree of protection. There's a lot of discussion about that regular surgical masks don't stop the virus getting around, but they do some useful things. They stop you from touching your own mouth and nose, and there's a very practical thing. They act as like a social distancing signal that sort of says people, hey, look, keep away, and that can be quite useful in its own right. You have to be careful with gloves, because a lot of it's about what you do with them afterwards. If you're wearing the gloves and then you still touch your face, then it's just as bad as your hands, if you know what I mean. So if you are wearing gloves, you want to dispose of them when you've been to the at-risk place. We've been, I don't know about your own units, but we've noticed that a lot of our patients know when the quietest times for blood tests are. I would caution that a lot of community testing labs are changing their hours or locations. So just keep on top of that. Maybe check the website of your community blood testing facility. And I would add that one other solution one of our patients came up with was that to avoid sitting in the waiting room for the blood test, they went with a partner who went in and took the ticket for them. and then called them out from the car when they were ready to go, so they didn't have to sit in the waiting room. You could try something like that. I would say that our blood testing labs, the phlebotomists are being really scrupulous about keeping the area clean, washing their own hands, and staying away. And just, you may find it gets hard if they may have staff sickness, and as they should. We shouldn't have phlebotomists with coughs or colds at this time. So yeah, good question. If you have a mask available, you could wear it. If you wear gloves, sure, but just make sure you take them off and dispose of them, and don't try and keep reusing them, and otherwise they're just as bad as your hands. We have some parents of pediatric patients, general advice for them. Well, one good thing about this, we've got to have a look at silver linings, is that children generally seem at very low risk of severe disease. Unfortunately, the one exception in that is only one reported case I know of, but a child after who was still on acute lymphoblastic leukemia treatment, who got a severe COVID-19 disease. So I think all the precautions we've talked about apply for children. I think overall, for whatever reason, no one really understands this, the risks for children seem to be much lower. But once you're on a very intensive chemotherapy, the risks probably are still there. And obviously, children need to be around their parents, so the parents should take great precaution to try and stay away from this as much as possible. I'm supposed to have a 3-monthly blood test. Should I still have it? Good question. So we are looking at reducing the frequency of blood testing. It's all about risk and benefit. So you might have a strategy where in normal times, for asymptomatic myeloma that's been stable for 3 years, we still recommend a 12-weekly or 3-monthly blood test. In this situation where there's this horrible infection that's been stable for a year, really what's the chance of things taking off in 3 months? Is 4 months okay? Quite probably, yes, 4 months might be okay. Ideally, I'd recommend checking with your own clinician. Perhaps you can, if there's a nurse specialist you can send a message to, or if they have an advice line you can ring, they might be able to find out. For most people on sort of routine bloods, they can be stretched a little bit. And I think that might be sensible, especially during this level 4 risk period. I can't get hold of hand sanitizer. Someone has suggested spray bottle with soapy water to wash my hands when I'm out and about and away from the sink. Do you think this could work? I think it could work. So soap does have an effect on the viral envelope, is what I understand. And I'd look at Susie Wiles's Twitter account for discussions of this. Exactly how that works in practice, you're going to have very soapy hands then when you're out and about. I'm afraid hand sanitizer is really difficult to get hold of at this point. And the best thing actually right now is to stay in anyway, not to touch your face or mouth while you're out, and then to wash your hands really carefully when you get in home. And yes, soap and water is actually effective. Simple soap and water or detergent, washing up liquid if that's what you've got, and a really good 20-minute hand wash. There are great videos online on YouTube about how to wash your hands. There are common areas that are missed, like the back of the hands and the wrists, and between the fingers, for example, the webs of the fingers. So you can go on YouTube and look at some hand washing videos and get some really great tips on that. And by all means, try the spray bottle if you'd like. Yeah. Can you reuse masks? Oh, I don't know. So I think it might depend on what you're trying to use them for. If you were trying to use them in a hospital setting where you're in a room with someone known to have or thought to have COVID-19 disease, then absolutely not. Because they might actually have it on the surface. If you're putting it on yourself just to protect yourself in the broader environment, they're probably okay to reuse, but you don't want them to keep reusing them once they get really damp, because then they can actually harbor viruses and bacteria. And I don't know if I can say more than that. It's a bit outside my domain. There's a great link on the chat section there, which actually just went to all the panelists. Actually, it's not gone. So Faith, if you could resend that link, but send it to all, there's a link on where you can apparently get some hand sanitizer if you wanted to get some. And have there any other outstanding questions you're aware of there, Matt? How about chloroquine, zinc, vitamin C, and alternatives? So unfortunately, we don't have any proven treatments for this disease yet. Chloroquine and hydroxychloroquine, anti-malarial drugs, they work on this virus in the laboratory, but they've not been shown to definitely be effective in humans. The trial, there's one small, tiny French trial out there, but it's not randomized. It's not really a proper study. Those patients might have been about to get better anyway. And bear in mind that chloroquine and hydroxychloroquine can also weaken the immune system. So I reckon it's best to wait for the proven treatments. Zinc and vitamin C are not proven. If you're going to go with vitamins, I just recommend sticking to recommended doses and not going super high dose, so you don't do anything harmful with them. The other thing to bear in mind, particularly if we're still in this sort of situation in winter, is a modest dose of vitamin D. So just the normal recommended daily dose, 200 to 400 units a day, has been shown in a big meta-analysis, which is a study of many studies, to reduce the risk of respiratory tract infections, so lung infections. And that was before COVID-19, of course, so we don't know about COVID-19. But it may be sensible, particularly if you're spending most of the time indoors and you're not getting sunshine, to think about just getting enough vitamin D for regular, normal replacement. So just 200 or 400 units a day. Don't go high dose with these things because you could cause harm, and the benefit is not certain. Follicular lymphoma patient with a partner who is a GP, what a great question. I think if you were very immune suppressed, if you've had recent chemotherapy, or if you've been within a couple of years of having fludarabine or bendamustine, and particularly if you're a partner of a doctor who is being exposed to COVID-19 disease at work, you might really want to consider finding an arrangement in your home to stay separate over this time, if that's possible. It's not easy, but you might want to consider that. And it is a problem. I'm a health professional, and you watch your family members with concern. But I think if you're immune suppressed and your partner is a health professional, see who's at a high risk of being exposed, see whether there's any changes to their work they can make, or see whether there's a way that you could set at the house to reduce some of those main contact things. And did you say vitamin D? Yes, I did mention vitamin D for Delta. Vitamin D is the one that's got by sunshine. We know that vitamin D levels get a little bit low in a lot of New Zealanders over the winter months, or when you spend most of the time indoors. And I don't try and take high doses, but a regular daily replacement dose of 2 to 400 units a day might be reasonable to do if you're mainly indoors. So asymptomatic myeloma, I think we've talked about. 2 years out from rituximab and in remission, do I need a flu jab? Yes, get a flu jab. If pretty much anyone with a blood cancer, it's reasonable to get a flu jab. And the flu jab does not contain any live virus. There's very few reasons not to take it. The one thing I would say is if you've got a very low platelet count, you might get a really big bruise at the injection site. So if you've got a very low platelet count, check with your doctor. They might need to give it as beneath the skin instead of deep into your muscle. But most people at the moment, I think, reasonable to give a flu jab. Any advice on how long the virus survives on surfaces and in the air? You can look that up. There's a bit of information about that. We think it's not so much that it survives, it remains infectious, because it's not actually alive, but we think it might remain infectious on some surfaces like plastics and metals for up to a few days, which is why it's important to clean them. And cleaning surfaces is quite simple. 0.1%, so 0.1% bleach solution seems to disinfect surfaces from coronaviruses, including this one. Do you need to make sure you're exactly a year out for each flu jab, or can it be give and take a month or two? So look, under normal circumstances, I recommend people wait at least 6 or maybe 12 months after rituximab chemotherapy to get the flu jab. But the reason for that is because the flu jab might not work fully. This year, there are big benefits to minimizing the chance of some other viral infection. So I'm just recommending people go ahead and get it anyway. Worst case scenario, you don't get that much protection. I'd still probably go ahead. I think probably we've answered most of those questions, Matt. Is that okay?
Yeah, that's beautiful. You knocked it out of the park, Rob. We're really appreciative of this entire session. Just sending it to the message box, but I know you probably can't hear them, but we're the hush of thank yous across the land, and yeah, very grateful from LBC. And there's been a beautiful team behind me keeping these questions organized, from Tim and Melody, Natasha, and some others. So thanks to everybody. Thanks for the update on COVID-19, and maybe we can have you back in the future. But again, thumbs up from us.
Well, thanks very much, everybody, and take care there. Look after yourselves. Look after your mental health and physical health as well, and stay active within your home if you can. Yeah, look, wish you all the best.
Okay. Thanks again, Rob.
Thanks, LBC. Thank you.
Take care.
Bye-bye.
See you, everyone.
Bye.
Bye.